As a quick note, a brief apology, I actually prepared about an hour's worth of material, but I'm going to just go through the key points here. So bear with me if you have any interest in learning more about my views of the comparison between ultrasonography, fluoroscopy, and literature support in favor of these two techniques. By all means, please ask the meeting supervisors for a copy of these slides. I'm going to just skip right to the heart here. I want to talk about several of the procedures that we commonly do in interventional pain management. And there are 9 procedures: stellate ganglion block, shoulder injections, chest injections for intercostal blocks, injecting the hip, knee, steroid injections used in the caudal space, sacroiliac joint injections, and then if time permits, just a quick overview of transforaminal injections. And you've heard some of this already. And we've heard about the advantages of ultrasound as well as some of the disadvantages of ultrasound and shortcomings, so I won't go through that. So stellate block, of course, can be performed using ultrasound guidance. That has kind of revolutionized our practices. We take a different approach. Instead of a perpendicular approach down towards chest and the tubercle, we go from lateral to medial and try to identify the structures, which is obviously in the neck, an area of great concern because of all the vasculature. These are some of the images you may see using ultrasound guidance. You can identify things that you don't see with fluoroscope. You can see the esophagus, for example. We realized we did thyroid biopsies on virtually every stellate ganglion block we ever did until the advent of ultrasonography. You can see the longest coli muscle, which is a target for our needle placement in the hyperechoic structure of the stellate ganglion, as well as the vascular structures, which, as previous speaker mentioned, you do not see when you're using fluoroscopy. And here's the technique, and this is the approach, and this is how our needle will be placed from lateral to medial. Whereas with fluoroscopy, of course, we have the advantage of seeing the osseous structures to a greater degree. So is there any benefit for the use of ultrasound versus fluoroscopy? Well, the studies would actually show that there is no benefit in terms of either efficacy, success, or complications. These are some of the studies which I referenced. This is a cadaver study just recently published, which showed that although ultrasound seemed to have a higher efficacy in cadavers for placing the methylene blue directly over the target, in point of fact, it was not statistically significant. Nice paper that was just published last year in regional anesthesia showed complication rates when stellate ganglion blocks are performed. Obviously, when we do a blind technique, that has the highest incidence. Almost 50% of all complications were when people use landmark techniques. But it was evenly mixed between fluoroscopy and ultrasound in terms of complications. Of course, we don't know the denominator, meaning how many cases were performed using fluoroscopy versus ultrasound. Now moving to the shoulder injection, of course, as well can be performed using either ultrasonography versus fluoroscopy. This is what we're targeting. We're looking for the fibrocartilaginous disc. We'll use our ultrasound guidance. This is a needle placed under ultrasound guidance. And this is what it looks like under fluoroscopy. Pretty much easily to visualize very superficial structures for the acromioclavicular joint as well as the glenohumeral joint. Here we're looking to place the needle over the glenoid process when we're doing our glenohumeral joint injection. Here's what ultrasound looks like. Is there any data to substantiate the efficacy or superiority of one of these techniques over the other? In point of fact, no. Whereas fluoroscopy was 80% successful with glenohumeral joint injections versus 93%, this was not statistically significant. Here's their more recent study for looking at injections using either ultrasound plus fluoroscopy versus ultrasound alone. Again, there was no statistically significant difference in outcomes, Oswestry Disability Index or pain scores and functionality, whether we chose to use fluoroscopy or ultrasound alone. Intercostal nerve injections, obviously we don't want to engender a pneumothorax. We want to stay away from the pleura and the pulmonary structures. And how do we do that? Well, clearly with ultrasound, we can see a lot of the things that we could never see with fluoroscopy. We can see the intercostal artery, the musculature, as well as the sliding pleura. And this is a nice view of that as well. We see a comet tail, a reverberation artifact, which Thomas Hogg just spoke about recently. But is there any data to suggest the superiority of ultrasonography versus fluoroscopy? And the answer, once again, is no. And that's true in cadaver studies. This is a nice paper from Michael Gofeld and Associates, which showed that although contrast was identified to be more successfully placed with ultrasonography, in clinical scenarios, this has not been borne out. And here's a nice study which goes all the way back to 2010 from my good friend and colleague, Dr. Shankar from Wisconsin, who looked at fluoroscopy versus ultrasound-guided intercostal blocks. In point of fact, fluoroscopy had a superiority in terms of pain reduction and the duration of pain reduction versus ultrasound. So I think it's a mixed bag whether we elect to use ultrasonography for our patients versus fluoroscopy. What about injecting the hip? Here's what we're looking for when we use the ultrasound guidance. We're trying to place our medications in the articular femoral joint space. It's also easy to perform this technique using fluoroscopic imaging. And a nice review in the Revista Brasileira de Reumatologia. I'm sure we all read that journal each and every week. This is a prospective study that showed that when we used fluoroscopy to inject the hip, joint flexion was better, but pain relief was superior when ultrasound guidance was included. And here's a more recent paper that showed that ultrasound, this was a prospective study, so it raises to the level of 2, level of evidence in favor of the use of ultrasonography in terms of, excuse me, the speed at which the technique could be performed and patient satisfaction. The outcomes were not different, but patient satisfaction was higher. Therefore, the authors claimed this was level 2 evidence in favor of using ultrasound guidance. What about injecting the knee? This is what we're looking for when we see ultrasound guidance. We can see a lot of things. We can see the musculature. We can see the menisci, for example. We can do this diagnostically. And it's an easy procedure to perform using the ultrasound technique, but it's also very easy to inject the joint space using fluoroscopy. This can be accomplished in a matter of seconds in most cases. And here's studies that show that ultrasound guidance, placing the contrast, the medication, I should say, into the joint space had a very high efficiency, 96.7%. This is not versus fluoroscopy, this is versus a blind technique palpation, where the efficacy was only 81%. We know that blind techniques don't work. We know that our orthopedic surgeon colleagues often miss the target when they do their joint injections. This has been borne out in the orthopedic literature, not just the pain literature or the anesthesiology literature. Caudal epidural injections, does it make a difference whether we select ultrasonography versus fluoroscopy? Again, the answer is pretty much no. The target here, sacral hiatus at the sacrococcygeal ligament, in trying to place our medication in for the lower sacral segments and possibly the L5-S1 nerve roots, can be accomplished using ultrasound guidance very easily, and it can also be accomplished very easily using fluoroscopy. This is what it looks like ultrasonographically. Here's what it looks like. Here's a nice Christmas tree representation from our use of fluoroscopy and the injection of contrast media. Here's one of the early studies from Lee and Associates, Lee and Park, 120 papers of patients, unilateral radicular pain. There was no difference between the groups, whether they had the technique performed under ultrasound guidance or under fluoroscopic guidance in terms of both pain relief as well as Oswestry disability index functioning at up to 12 weeks. The same authors looked at a different series of 110 patients. This was their next study in 2015. And they carried out the study not for 12 weeks, but actually for 12 months and found, again, no difference in pain scores, no difference in functionality, whether caudal injections were performed using ultrasound guidance versus use of fluoroscopic imaging. So it's a wash. Take your pick. Whatever you're more comfortable with, whatever you're more competent in, that's what you ought to be doing. A more recent study that was published in the Turkish literature, however, suggested that it was faster to do a caudal injection using ultrasound guidance. I would respectfully disagree with this. However, the pain levels and functionality were no different between the two groups, as borne out by a more recent study also published in the Turkish literature, here it is, that showed identical changes in VAS scores over time, as well as identical changes in functionality, Oswestry disability indexes over time, whether you selected the use of ultrasound guidance versus fluoroscopy. SI joint injections, many of us find that the use of ultrasound is acceptable for this technique. You can see the ilium, the needle track, and the sacrum here. This is what it looks like fluoroscopically. Our first speaker gave a beautiful representation of that. It's easy to do these techniques, but is it effective, is it safe, and does it change the outcomes for our patients? So here's a technique, which a study from 2014 that showed that the accuracy of placing the medication into the SI joint was higher with fluoroscopy than with ultrasound guidance, 98.2% versus 87.3%. This was not statistically significant, however, and the use of ultrasound was eminently better to find the vasculature around the SI joint. A more recent cadaver study, however, showed that the success rate was much higher with fluoroscopy. 10 out of 20 or 50% of the needles were appropriately placed versus only 1 out of 20 using ultrasound guidance for SI joint injections, and that was because the intra-articular position of the needle was not visible and was blocked by the posterior superior iliac spine. I'm going to finish up. This will be the last block I'll talk about in reference to time. Trigeminal nerve block. One of my former colleagues, Dr. Tony Nader from Northwestern, who I trained, a brilliant young man who studied the use of ultrasound guidance for V2 or maxillary nerve blocks at the foramen rotundum, and has published several papers on this concept. He described 3 different techniques for placing the needle into the foramen rotundum: the posterior infrazygomatic approach, anterior infrazygomatic approach, and the suprazygomatic approach. It's kind of tedious. I have some of his patients available to me. They come to my pain clinic every now and then. Sometimes these blocks take up to 45 minutes. I do these procedures exclusively under the use of CT imaging and with 3-dimensional reconstruction. I have a clinic overseas from the United States. We take care of patients with trigeminal neuralgia. We inject stem cells for this purpose. We have 3-dimensional reconstruction, putting the needle into the foramen ovale. We have 100% success. These techniques take an average of 7.5 minutes to perform. So yes, there's radiation exposure. There's no question about it. But in terms of efficacy and in terms of safety for our patients, I believe that finding the target and seeing the target and being unequivocally sure when you're injecting in the head and neck that your needle is in the foramen ovale makes eminently good sense. I'm going to finish there. I won't talk about other topics. There's a lot to go through. I'll just leave it by saying that ultrasound has proven to be safe for some, but not all interventional pain management procedures. I certainly don't use it for articular facet injections. So that's where Thomas and I might disagree. And for transforaminal injections in the neck, I do not even perform those techniques any longer. It's useful for stellate ganglion block, intercostal nerve block, certainly for peripheral joint injections, and possibly for caudal and SI joint. I don't think it's as safe as fluoroscopy for when we're talking about neuraxial blocks. And the best use of ultrasound is when the target is superficial, where there's vascularity. I would raise caution for cervical medial branch blocks and for lumbar and cervical transforaminal injections. Even when you have to find the vasculature, I still rely heavily on fluoroscopy as I was trained. For trigeminal nerve block, I believe in the use of 3-dimensional reconstruction using a CAT scan, but there is no data to support that premise. That's only my clinical impression.